everybody, so we're going to discuss some diabetes presentations on the wards. So as we all know, there's multiple types of diabetes that we may come across in hospitalised patients. The most common ones are highlighted here in red, and they would be type 1 diabetes, type 2 diabetes, patients with pancreatic insufficiency or type 3C diabetes, and drug-induced diabetes. The commonest drug we would see implicated would be corticosteroids. However, we are seeing more and more patients with immunotherapy-related diabetes. We are seeing more CF or D or cystic fibrosis-related diabetes, as patients with cystic fibrosis are now living longer and living better, full stop. We more rarely see secondary diabetes. This may be secondary to other endocrine causes such as acromegaly or Cushing's syndrome, and MODY and mitochondrial diabetes are rarer inherited forms of type 2 diabetes. So I'm going to take us through a case. This is a patient who presents very frequently to hospital. She's 21 years old and was diagnosed with type 1 diabetes at the age of 15. She lives with her mother and stepfather, and her father is in prison. Her social circumstances have consistently been poor. She has always had poorly controlled diabetes with a HbA1c ranging from 100 to 130 millimoles per litre, and she has very frequent admissions with ketoacidosis. So on this presentation, she attends ED complaining of vomiting, abdominal pain. She is drowsy and she is clinically dry. She's hyperglycemic with blood sugars of 35 millimoles per litre and has severe ketonemia with ketones of 7.5 on a finger prick. She has metabolic acidosis with a pH of 6.8 and a bicarbonate of only 5.1. So she's got a severe ketoacidosis. So for the vast majority of patients presenting with DKA, the presenting reason will be due to insulin omission, full stop. With this patient, I think we need to think a little bit more clearly about why she isn't able to take her insulin regularly. She has got difficult social circumstances, there's a lack of support at home, and unfortunately the hospital has become her safe place. And we need to think about how we can support patients like this going forwards. The criteria for the diagnosis of DKA are actually very straightforward. You need to have hyperglycemia, so that's the D. You need to have elevated blood ketones or significant ketonuria, and have an acidosis with a venous pH of less than 7.3 and or a bicarbonate of less than 15. We treat this as a diabetes emergency. All patients need an urgent review by either the diabetes team or the medical registrar on call. IV fluids, IV insulin and close monitoring would be the standard of care. And there are guidelines on Q-pulse for the management and the administration of insulin. As this young woman was very unwell, she was admitted to the intensive care unit, was intubated and ventilated. She was given intravenous antibiotics due to a concern about an underlying infection, and she was treated as per the DKA protocol. She rapidly improved with her acidosis resolving and her blood sugars normalizing. DKA is unfortunately still a very common complication of type 1 diabetes, occurring in about 8.6% of type 1 patients per year. The National Diabetes Data Group suggests that there are 3 to 8 episodes per year per 1,000 type 1 patients, and luckily the mortality has fallen significantly in the last 20 years, from a peak at 8 to 10% to less than 1%. And this is due to very careful management of DKA in hospitalised patients. The female to male ratio remains approximately 1.8 to 1, and this is certainly reflected in our patient load here in University Hospital Waterford. So the definition of DKA is a state of absolute or relative insulin deficiency leading to hyperglycemia, dehydration, lipolysis and acidosis. It is a medical emergency and must be treated as such. The pathophysiology is insulin deficiency. This causes hyperglycemia, which stimulates lipolysis with the formation of ketone bodies. Patients will then also develop a metabolic acidosis. Patients become hyperglycemic, become polyuric and dehydrated, which stimulates the release of stress hormones such as cortisol, adrenaline and noradrenaline. And these again stimulate further lipolysis, contribute more to the hyperglycemia, enhance hepatic breakdown of glycogen and drive the cycle towards dehydration and acidosis. And this is just a pictorial explaining that. Clinically, these patients come in with osmotic symptoms, so polyuria and polydipsia. They will frequently complain of nausea and vomiting, and this is due to ketosis. They will be clinically and biochemically dehydrated. Often they'll be drowsy, and in more severe cases they may be stuporous. They will be tachypnic, and this is what we call Kussmaul's respiration, and this is secondary to their metabolic acidosis. Those of you who can smell ketones may notice the smell of it on their breath. They have abdominal pain. They may have gastroparesis, and you may hear what we call a succession splash if you examine their abdomen, and they may well have absent bowel sounds. It is important to note that abdominal pain in DKA should not be assumed to be simply due to the DKA, and other causes should be ruled out, particularly appendicitis and ectopic pregnancy, which would all be quite common in our cohort of patients. The commonest precipitant by far is insulin omission. The majority of patients who come in with DKA will either have forgotten their insulin or purposely omitted it. Stress of any sort can precipitate a DKA, so pneumonia, gastroenteritis, UTI. And a common issue in these situations is that patients panic and worry about hypoglycemia, so they omit their insulin or reduce their doses and then develop a cycle of worsening hyperglycemia and ketosis. Other presentations can be due to pancreatitis, myocardial infarction, stroke, trauma. Alcohol would be a common precipitant, and also illicit drugs, in particular stimulants such as cocaine or amphetamines. We also see it quite frequently in a newly diagnosed patient, and this is because these patients are not aware of their illness. There have been a lot of education campaigns run in recent years, and we are now thankfully seeing fewer patients present with DKA as their first presentation of diabetes. So the treatment goals are appropriate fluid replacement to correct hypotension, restore circulatory volume, clear ketones, and correct the electrolyte imbalances. Patients require insulin in order to treat their hyperglycemia, and we need to carefully treat and prevent the complications of DKA. The majority of patients will have a significant total body water deficit and also deficits in sodium, chloride, potassium, and phosphate. We treat these patients with a litre of isotonic saline over the first hour and then further bags over 2, 4 and 6 hours, and we reevaluate at that point. We add potassium from the second bag even if the patient has a normal potassium level. We do need to exercise caution in some patient groups, so young people, particularly those with a low body weight, aged 18 to 25, who are at increased risk of cerebral edema, and we would recommend that patients who are 18 to 25 and under 50 kilos be treated as per the paediatric protocols. Elderly patients, pregnant women, patients with heart failure or kidney failure or other serious comorbidities, all of these patients should be admitted to HDU or ICU, where we can replace their fluids more cautiously and use CVP measurements to guide their replacement. We give insulin in the form of fixed dose insulin infusion at a rate of 0.1 units per kilogram. and we will only give a stat dose of insulin if there's a delay in setting up the IV insulin. We give our basal insulins as usual, and if the patient is newly diagnosed, just start 10 units of Tresiba or Toujeo that evening. Once sugars drop to less than 14, start 10% dextrose alongside the sodium chloride in order to clear ketones and manage the DKA more rapidly. We continue the fixed rate infusion until ketones are less than 0.3, pH is greater than 7.3, bicarbs greater than 18, the patient is well, not vomiting and wants to eat, and at this point we can switch to subcutaneous insulin. If the patient is not hungry and doesn't want to eat, or is still quite nauseous but their DKA has resolved, they can be switched to a variable rate insulin infusion at this point. Potassium is probably one of the biggest things that has made a change in our mortality rates. In patients with DKA, often they will present with hyperkalemia, however they will have a total body potassium deficiency. At presentation, potassium may be elevated and this can cause cardiac arrest. However, once insulin and fluids are started, potassium level will fall rapidly. So these patients should have ECG monitoring, and we start to add potassium once the potassium is less than 5.5 to the second bag of normal saline. Patients should have hourly blood glucose and hourly ketones initially, and should have urea and electrolytes, plasma glucose, venous pH or bicarbonate at baseline, and 2, 4, 6, 8, 12, 16 and 24 hours treatment. The acidosis will correct with rehydration and fluid replacement, and we don't usually use bicarbonate unless there's a very severe acidosis, and this should only be done in the intensive care setting. And this is because it may cause a paradoxical worsening of CSF acidosis, hypokalemia, fluid overload, and cause increased risk of both pulmonary and cerebral edema, especially in children and young people. We aim to have ketones falling by 0.5 millimoles per hour, glucose falling by 3 millimoles per hour, and bicarbonate rising by at least 3 millimoles per hour. We also must then think about the trigger for these episodes. Eating disorders are quite a common trigger for a recurrent DKA. Is there an issue with drug abuse? Is there an issue with alcohol misuse? Are there difficulties at home? Are there reasons that the patient is unable to manage their insulin and manage their diabetes? Is there signs of underlying infection or MI or stroke? I mentioned earlier that we need to treat the complications, so if there's vomiting or absent bowel sounds, we usually insert an NG tube just to prevent aspiration and decompress. We usually look for an underlying infection and treat as appropriate because these patients are so dehydrated that are at very high risk of DVT and PE, so we would always use thromboembolic prophylaxis. We try to rule out an ischemic event. We also will monitor for the development of cerebral edema, and hypoglycemia can occur if we are overly generous with insulin. And we need to always educate and re-evaluate these patients regarding their diabetes control. So in conclusion, diabetic ketoacidosis is a medical emergency. Patients should have blood ketone measurements where possible. IV fluids, fixed dose insulin infusion are the mainstay of care, and all patients should have their subcutaneous basal insulin continued. So here's another case. This is a 36-year-old gentleman with type 1 diabetes. He usually has very well controlled diabetes. He's on Tresiba 22 units at night and Novorapid pre-meals. He was admitted with acute abdominal pain, and his CT abdomen shows acute appendicitis. And James is a patient that I would normally see every 6 to 12 months in my clinic. He's very well controlled and seldom requires any intervention, as he is very competent at managing his own diabetes. He fasts for theatre the next day and surgery goes very well. However, following the procedure, he becomes increasingly hyperglycemic and his ketones are 6.5. And I'd just like everyone to have a think about what might have gone wrong here. So what's clearly happened here is that this gentleman has been fasted and his basal insulin has been omitted. And this was a particularly distressing case because James was begging for his insulin to be given. and he actually contacted the diabetes nurses himself post-operatively, saying that he was in DKA. This is the type of situation we're trying to work to avoid in the hospital. So here's a totally other case. This is Mark. He's a 65-year-old man. He's a smoker, he's overweight, and he's admitted with infective exacerbation of COPD. He's treated very appropriately with steroids, nebulizers and antibiotics, but his sugars are noted to be elevated, between 5 and 11 in the mornings, but up to 8 to 18 in the evenings. So what do we do here? So we need to think about the cause. I mean, this is classical steroid-induced hyperglycemia. Steroids are potent anti-inflammatory drugs, and they're used in about a quarter of our inpatients, so it is important that we're aware of this. And they're associated with a rise in glucose, which may be temporary, and for some patients may be permanent. We can become very cavalier about using steroids in hospital, but it's important to remember that 5 milligrams of prednisolone is equivalent to 20 milligrams of hydrocortisone, and therefore that standard dose of 30 to 40 milligrams of prednisolone is equivalent to 120 plus milligrams of hydrocortisone. Dexamethasone is particularly powerful, with 0.75 milligrams being equivalent to 20 milligrams of hydrocortisone. And methylprednisolone, which will be commonly used in neurology and in rheumatology patients, is again 5 times as strong as hydrocortisone. Our target inpatient glucose would be 6 to 10 for the majority of patients, but 6 to 12 can be acceptable. In the beginning of the COVID pandemic, we were aiming for sugars of less than 10, but again, we could probably aim for a little bit higher at this point. For patients and care home residents and end-of-life care, we tend to aim for sugars in the safe range rather than aiming for tighter control, and this is because the risk of hypoglycemia in these patients is significant. In patients without pre-existing diabetes, we would advise monitoring their blood sugars once steroids are started at least once a day, and that should be ideally done in the afternoon or evening, because steroid-induced hyperglycemia tends to be worse later in the day. However, if the glucoses are found to be elevated, we should increase the testing frequency, and patients with known diabetes commenced on steroids should have QDS finger pricks performed. This is an algorithm published by the JBDS, and it's very useful, and we will be publishing very similar guidelines here in the hospital. All patients with steroid-induced hyperglycemia are at high risk of future diabetes, and therefore this is a really good opportunity to counsel them regarding diet, exercise and weight loss. Another common complication of diabetes in hospital, this is Mary, an elderly lady who has very long-standing, well-controlled diabetes. She's on metformin, gliclazide and canagliflozin, and she's admitted with a UTI and delirium, and her glucose after breakfast is 2.1. So I hope everybody here now knows that we have hypoglycemia boxes on the wards, and all patients should be treated with oral glucose in the form of a lift drink, and use IV glucose only if the oral route is not available. But I also wanted to point out that this is an opportunity to review her medications as a whole. If her appetite is poor and she's not eating well, as delirium would suggest, drugs which cause hypoglycemia should probably be held, and in this case that would be the gliclazide, and it can be a really good opportunity to highlight to the medical teams that this might be to think about. And these are our hypoglycemia guidelines, which are available on QPulse. Another diabetes emergency we see in the hospital. This is a 79-year-old retired farmer. He lives alone, he's found drowsy and confused, he's incontinent and unkempt, and on arrival to A&E, he has a very profound acute kidney injury with severe hypernatremia. He is mildly acidotic, and his venous blood glucose is 79.8. His ketones are 2.2, so only very slightly elevated. And this is a condition which is thankfully quite rare, but is the hyperglycemic hyperosmolar state. And these patients are extremely hypovolemic, they're extremely hyperosmolar and have very severe hyperglycemia without a significant acidosis or ketonemia. This is a state of extreme dehydration and it develops over days to weeks, usually in a setting of intercurrent illness. It's a life-threatening emergency. The mainstay of treatment is fluid. Many patients do not even require insulin, and once they're rehydrated, their blood sugars will come down quite rapidly. However, it has an approximately 20 to 30% mortality, even with best. It is much less frequent than DKA, but much higher mortality, probably because it tends to occur in frailer, more elderly patients. Unlike DKA, this develops over days to weeks rather than over hours. Unlike DKA, it is usually associated with infection and is often complicated by vascular events such as stroke, thromboembolism, or myocardial infarction. The goals of treatment are similar to that of DKA. We wish to normalise the osmolality, replace the fluids, normalise glucose, prevent thrombosis, prevent cerebral edema, and prevent foot ulceration. Because these patients tend to be very drowsy and bedbound, they are at very high risk of acute pressure ulceration, both in their feet and in their sacrum, which would mean that ICU would not be appropriate, and it is important that they're reviewed by a senior clinician very, very soon after presentation. In the recovery phase, which is where you will see these patients on the wards, it's important to recognise that these are frail and elderly patients, so early mobilisation is crucial. Diabetes education is required, as is ensuring adequate fluid intake. And we've talked a lot about diabetes emergencies, and I'd like everyone to have a think about how we can make hospital stays easier for patients with diabetes. The majority of patients with diabetes will say that hospital stays are terrifying for them. They find that their insulin is often not given as prescribed. They find the lack of control, particularly patients with type 1 diabetes, very, very difficult. They don't have much control over what they eat. Hospital meals are often quite small. Carbohydrate counting is not available on the menus. So I think we do really need to think about how we can improve the quality of life for patients with diabetes in hospital. And thank you very much for listening.